Let me sort out a couple of things. I'm still in the hospital, so imagine. Still in the hospital, so now let's close this. This. Let me check if the chat function is working all okay. Hi, everyone. Put something on the chat. Just check that the chat function is working okay for everyone. Perfect. And just tell us where are you joining from today. It will be great to see how many people are online. We're expecting the numbers to be slightly less because this is a non-technical webinar but we still have nearly 1,000 registrations, so hopefully 400 500 of you will be online. We'll start soon. Just give me a couple of minutes. Perfect. So I'm not sure if Ash will be able to join because I think he's stuck in theater in India. And webinars, treatment side effects. So good evening, everyone, and welcome to webinar number 80 of iBreastBook. It's great to see that we're still getting numbers and still getting people from all across the world. It's great to see we have an excellent panel with us. Usually we try October time to make the webinar slightly a bit less technical, a bit less about treatments. It's more about survivorship and other issues in relation to breast cancer treatments. So we have two themes today. We have a theme about side effects of treatments, especially chemotherapy and endocrine treatment, as we're treating now breast cancer as a chronic disease. Ladies are living long, and we just need to know how to deal with that. And the other part of that will be talking about lifestyle measures and breast cancer and about things like exercise, things like diet, things like weight, and we'll see how they affect survivorship, as those are very important things. We have great speakers from all across the world. We have Marjolin Smidt from the Netherlands. We have Sani also from the Netherlands. We have Emma Spurrell and Fharat Raja from the UK. We have Jehanis from the USA. And we'll see if uh, Ash Kotari will be able to join or not from India. We have all four language channels on top of the English channel. So we have Akram Girgis, he's doing Arabic, and we have the lovely Ricardo Pardo will doing Spanish. We have Michele Sorotas doing Italian, and we have Tatiana, where's Tatiana? She's doing Russian channel, and maybe from next webinar we might have also a Portuguese channel. So let's see how things go with that. It's great to see so many of you. Terri, I might just get you on board on the panel. So it's great to see you online here, Terri. Now, let's start with the talks. So the first talk will be about endocrine treatment, side effects, management, and how to deal with them. And we have Emma Spurrell from the UK who's going to give us the first talk. So Emma, the next 15 minutes are all yours.
Thank you, Yazan. Let me just check I'm sharing. You can confirm you can see that.
Perfect.
Fabulous. Okay, well, thank you for inviting me to give a talk about the management of the side effects of endocrine treatment. I've only got 15 minutes, so I'm going to dive straight into menopause, which we all know is a low estrogen state and has a multi-system effect on the female body, many of which are made worse by the hormone blocking treatments that we give for treatment of breast cancer. I'm not going to talk about HRT today because generally we avoid that, but I'm going to talk about the other options that we have for managing some of the more problematic menopausal symptoms. So starting with hot flashes and night sweats, which can be really problematic, particularly nocturnal symptoms, causing lots of fatigue, and that goes on to affect cognitive function, mood, anxiety levels, and I think it's really important that we approach these early on in treatment. There are two different ways of approaching this, and I've really box them into the non-pharmacological and the pharmacological. And certainly my approach is to try and encourage the non-pharmacological treatments of vasomotor symptoms early on in the management of symptoms when women start endocrine treatment. And there's lots of different things. CBT is increasingly being used, and a lot of our clinical nurse specialists are now trained in CBT and can train patients in the CBT techniques to help with symptoms. There's hypnosis. I'm quite a fan actually of acupuncture. I've seen lots of women benefit from this, but you have to keep doing it. It often requires a number of treatments and regular treatments, but it can be really effective. There's the general relaxation techniques such as yoga and mindfulness, and then there are some physical techniques, so things like the cool pad pillow topper, which draws heat away from the body and can be helpful at nighttime, use of a fan, bedroom and during the day, and of course layering, and that includes clothing and bedding. So I think most of those people are familiar with, but I'm going to go on now to talk about the more pharmacological side of management of vasomotor symptoms, and have sort of they come in essentially 5 different categories of drug class, really. I'm going to talk a little bit about those and some of the data behind them. So the ones we're probably most familiar with are the SSRIs and SNRIs, which are this sort of antidepressant class of drugs. And venlafaxine is the agent that probably has the most data behind it. There are 5 randomized controlled trials looking at use of venlafaxine in women with ER-positive breast cancer. The dose range is quite low to begin with at 37.5 milligrams, escalating up to 150 milligrams, depending on symptom benefit. And the studies have persistently or consistently shown a significant reduction in physiological and self-reported hot flashes when compared up front with placebo. There are sort of more patient-reported outcomes of improved fatigue, mental health, and sleep. It has been compared head-to-head with clonidine, and in general, it's considered to be superior in the studies. But like all treatments, it does come with some side effects, and sometimes what patients don't like are the dry mouth, constipation, and nausea. Similar to venlafaxine, paroxetine is an SSRI, and actually in quite low dose at 10 milligrams, paroxetine is also beneficial, significantly reducing hot flush frequency compared to placebo. And you can see it's there's quite a significant difference between the two. Paroxetine has been looked at in a couple of doses, 10 milligrams and 20 milligrams, and in fact there's no additional benefit at higher dose. So these low dose antidepressants are very effective, and of course you got less side effects at lower dose. We tend to be a bit cautious with paroxetine in combination with tamoxifen because paroxetine is a cytochrome P450 inhibitor, which may render tamoxifen less effective. And so generally we tend to avoid co-prescription of the two, although even the data there is a little bit mixed, but on the whole, we avoid prescribing both together. Citalopram can also be beneficial. There's a couple of randomized controlled trials. Again, significant reduction in hot flash score. And again, as you escalate up the dose, it doesn't really make a big difference. So these drugs are effective at low dose. But citalopram can sometimes cause a bit more sleepiness, excessive perspiration, palpitations, and again, dry mouth. So moving on to the drugs that we tend to, these are the neuropathic agents that we commonly use for neuropathic pain, but they also have benefit in managing the vasomotor symptoms of menopause. Gabapentin has 4 randomized controlled trials behind it, looking at its use in women with breast cancer. And again, it reduces hot flash frequency and severity compared to placebo. It's given at its usual dose of about 900 milligrams per day. And actually, it has been compared head-to-head with venlafaxine, and they're both effective, about equally as effective. But on the whole, patients in the study preferred venlafaxine, 68% versus 32% with gabapentin, and that's probably the side effect profile largely. Similar to gabapentin, there's pregabalin, again, has similar effects to gabapentin, but they can both cause side effects, sleepiness, cognitive change, blurred vision, and sometimes weight gain. And I think when you decide what you're going to prescribe, it depends on the clinical scenario in front of you. So you may have a situation where actually you have a patient who's got, neuropathic pain post-taxanes, for example, with vasomotor symptoms, where you might actually want to pick something like gabapentin or pregabalin to treat both. Clonidine, we're all familiar with. It's licensed for the management of hot flushes. It's an alpha adrenergic agonist. Again, the starting dose is 25 micrograms, so quite low, twice a day, increasing to 50, 3 times a day. There's a single study that's compared it to placebo, showing a reduction in hot flash frequency and severity, but it can cause side effects, and in particular, the low blood pressure can be problematic. And if you do have somebody on clonidine and you're going to take them off it, you have to withdraw them slowly to avoid rebound hypertension. And again, I've already alluded to the fact there was a head-to-head comparison between clonidine and venlafaxine, with venlafaxine being superior in terms of efficacy. Oxybutynin is also commonly prescribed for vasomotor symptoms. It's an acetylcholine antagonist, actually used primarily to treat overactive bladder, so urge incontinence or stress incontinence, starting at 2.5 milligrams twice a day, when you can increase it up to 5. It is an acetylcholine antagonist, so it does come with some of the side effects that you might expect, which can be unpleasant. So in particular, the dry eyes and mouth and the diarrhea, but it can also cause nausea and headaches in some patients. But again, depends on what you're trying to achieve with your treatments. And if you have got somebody with urinary symptoms or bladder instability, you may want to try this drug to sort of double benefit with the bladder stability and the vasomotor control. So the neurokinin antagonists are a newer bunch of agents. They work on the NK receptors in the hypothalamus. In essence, in the state of declining estrogen, as occurs in natural menopause or induced by GnRH analogues, you get hypertrophy of these receptors and actually elevation in their ligands, including neurokinin B and substance P. And all of these are involved in thermoregulation within the hypothalamus. So the first agent made available was fezolinetant, also known as Veoza, which is an NK3 antagonist. And it's got very good data to show a reduction in hot flush frequency and severity compared upfront with placebo. The only problem is that the studies that were done did not include women who were on treatment for breast cancer, and therefore it doesn't have a license for these women currently. But there is a new agent out there which as yet doesn't have a license, but it has been through clinical studies. This is elinzanetant, and it's been looked at in women who are experiencing vasomotor symptoms from endocrine therapies for breast cancer. And that is the, I can't seem to move the slide on. Yeah, there we go. This is the OASIS 4 study, which was a double-blind randomized phase 3 study looking at women with ER-positive breast cancer who were either on tamoxifen or AIs with or without GnRH analog, depending on menopausal status. And the primary endpoint really was the frequency and severity of vasomotor symptoms. The study was for a year, but for the first 12 weeks, there was a randomized component, elinzanetant versus placebo. And after 12 months, all patients were on open label elinzanetant. And this is really a summary of the data. So this shows the change in frequency of moderate to severe vasomotor symptoms over the year of treatment. And you can see that in the first 12 weeks, where the study is randomized, there is some benefit with placebo, as often does occur, but actually the active drug is reducing vasomotor symptoms by about 50% compared to placebo. And importantly, when the placebo arm are administered the active drug from week 12 onwards, actually their vasomotor symptoms come under much better control in line with the active agent. Again, demonstrating that it does appear to have good disease activity, good vasomotor control activity in women taking endocrine treatments for breast cancer. I'm not going to go through the safety data, but essentially it's a well-tolerated drug with no significant toxicity so far, unlike fezolinetant, where there is some need to monitor liver function. The breast cancer outcomes were not part of the study. So I'm going to move away now from hot flashes and talk a little bit now about the genitourinary side effects of the endocrine treatments that we give. We know, obviously, in the low estrogen state, women can get a lot of vulval and vaginal atrophy, can lead to a lot of dryness, sometimes vaginal stenosis. And this results in a number of symptoms ranging from sexual dysfunction to recurrent urinary tract infections, thrush, urinary incontinence, and these can be really obviously very problematic. So with genitourinary symptoms, the first thing that I advise for patients is the use of the non-hormonal, more water-based, containing topical treatments. And women, it's important that they understand that there are two different types of treatment. There are the moisturizers and the lubricants, and they are different and used differently. The vaginal moisturizers are important because they need to be used regularly. So that's once every 2 or 3 days. They're administered locally, and they essentially push water into the tissues and improve the pH of the tissues, but they have to be used regularly and they have to be used ongoing. And then the vaginal lubricants are an additional agent to improve penetrative sex and make it less painful. The question, though, is whether it's safe to prescribe vaginal estrogens after a diagnosis of ER-positive breast cancer in women that are taking estrogen-blocking treatments. And the answer is there's no randomized data. This is quite a small slide here, and I don't expect you necessarily to be able to read the tiny print, but essentially this was a paper that had a look at some of the outcomes of the different topical preparations. And with the estrogen-containing preparations, the Vagifem and the vaginal ring pessary, they had a look to see whether there was a rise in serum estradiol in women who were using these agents. And in essence, certainly with some of the slightly higher dose preparations, there is a rise in serum estradiol, and it can get up to about 35 picomoles per litre. It can settle, but there's certainly an indication of a rise. And if you look at the sort of plasma estradiol levels that you expect to achieve following aromatase inhibitor administration, actually the estradiol gets really very low, down to almost 3 picomoles per litre. This is below the sensitivity of most of the assays that we use, but it implies there's the possibility that actually these preparations might sort of reverse the effects of aromatase inhibitors, but we don't have strong clinical data for that, although we do have some data. And this was a Danish observational study published in 2022. They have very good prescription data. They have good registration of prescribing activity. And they basically looked at their cohort of postmenopausal women diagnosed with ER-positive breast cancer between 1997 and 2004. And these were women who were being prescribed tamoxifen, AIs, or a sequence of both. And they looked at the co-prescribing of vaginal estrogen therapy, or HRT, in these patients. And this essentially is a table of recurrence amongst these patients who used HRT or vaginal estrogens. The first thing to say is the cohort in total was over 8,000 patients. The HRT group was really tiny. So although the hazard ratio is only 1, I don't think you can really draw any conclusion of safety with HRT. But just over 1,000 were being co-prescribed vaginal estrogens. And of these, there were about 300 taking tamoxifen, or just over 400 receiving an aromatase inhibitor in some form. And although overall the hazard ratio was 1, there was some suggestion of increase in risk where the hazard ratio goes to 1.39 in women prescribed vaginal estrogens in combination with aromatase inhibitors, which you didn't see when they were prescribed with tamoxifen. So I think this is always a nuanced discussion with women about safety of vaginal estrogens with aromatase inhibitors. I feel confident that there is safety with tamoxifen, and in women who are high risk and are going to need to take vaginal estrogens on a long-term basis, these women may well be safer actually with tamoxifen rather than an aromatase inhibitor. So I'm finally, if I have time, going to look at management of bone health, because obviously we know that low estrogen state accelerates loss of bone density. Aromatase inhibitors increase this rate of bone loss and they increase fracture risk. And actually, tamoxifen in premenopausal women is associated with loss of bone density, although the converse is true in postmenopausal women. Premenopausal women who are receiving ovarian suppression are at quite significant risk because they are losing their years of bone mineral density early on, and therefore they end up with a lower final peak bone density. It's important that all women have their lifestyle factors optimized. So vitamin D is key, and loads of people are vitamin D deficient. And actually, you need to be aiming for levels between 80 to 100 nanomoles per litre. And some patients do require quite high doses to achieve that, depending on variable absorption. Smoking reduces bone mineral density, as does alcohol intake, so reduction or cessation of both. Weight-bearing exercise, we all know about. Dietary calcium is important. And of course, comorbidities. So some women may be taking corticosteroids for other reasons, and that will have a negative effect on bone density. So this is my final slide. This is essentially a joint position statement on the management of bone density in women at high risk for bone loss following a diagnosis of breast cancer. And high risk for bone loss includes taking a aromatase inhibitor or being on ovarian suppression if you're a younger premenopausal woman. The low risk group really are those who have a T-score of greater than -2 and no additional risk factors. And in these patients, exercise and lifestyle factor modification is enough, and they need their bone density monitoring every couple of years. And you're looking out for a more than 10% loss of bone density at any site on average. The higher risk group are those who either have a T-score of less than -2, or they're at high risk for bone loss and they have additional risk factors as stated here. And in these patients, anti-resorptive therapy is recommended along with the lifestyle factors, along with continued monitoring of bone density every couple of years. So what anti-resorptives do we use? Well, on the whole, we will primarily go for a bisphosphonate, usually zoledronic acid, because we know that there is data with the bisphosphonates in terms of reducing risk of breast cancer recurrence in bone, as well as improving bone mineral density. But if patients cannot have a bisphosphonate for any reason, and sometimes that includes renal function, then the other option is denosumab, also like zoledronic acid, given once every 6 months. But usually denosumab does have to be followed by some sort of bisphosphonate because there is a rebound osteoporosis that occurs on cessation of denosumab. So essentially, I don't think the protocol has changed hugely. We've been following this for some time now. Perhaps it's a little bit more rigorous in terms of other risk factors and bringing anti-resorptive therapy in a little bit earlier. So I think I have reached time. I'm going to stop there. Just one more comment to make, and that is that actually there are other things to think about in the postmenopausal woman, and that's definitely the metabolic symptoms of menopause and the metabolic effects of drugs, particularly aromatase inhibitors, on causing hyperlipidemias. Women often get quite a bit of insulin resistance, and there are lots of cardiovascular risk factors associated with that. So that is also important to think about and address. And Yazan, I'll end there.
That's great talk. Thank you for that, Emma. And it's lovely to see nearly 500 people online. We have 460 people online, which is great. of course, something non-technical. Now, we'll take the questions after Fharat's talk because they're two related talks. There's quite a few things on the Q&A section, Emma. If you can have a look at those, if there's anything you want to answer live, answer live. If there's anything that you're happy just to type the answer there, please do that. And please, everyone, just put the questions in the Q&A section. All four language channels are working fine for Spanish, Italian, Arabic, and Russian. So if you want to listen to the talks in any of the languages, please join uh, those channels. Now, the next speaker is Fharat Raja. I'm trying to multitask. It's not working well with me, but I'm trying to do that. I'm trying to
You're
open,
doing it very well, Yazan.
I'm trying to open your talk now, Fharat, so that we can
Thank you.
start the talk. So Fharat is going to talk about management of side effects of chemotherapy. And
Thank you, Yazan. And it's wonderful to be speaking to so many people on a Saturday afternoon for me and morning and evening for many of you around the world. My name is Fharat Raja and I'm a consultant medical oncologist who works here in London at UCLH in the Royal Free Hospital. And I'm here with my colleagues Yazan and Dr. Emma Spurrell. I've been given quite an interesting task, really. So I think as breast oncologists, we are so zoomed in to what we do that we tend not to step really far back and look at the whole of our treatments and look at the whole of the side effects that we have to deal with. So I'm going to try and pick out a few points really and discuss a few issues with regards to the treatments that we give in breast cancer. Before I start that, I think it's important to have a context, and going on to the next slide, I will start with some statistics that we have. And we can see here, this is all UK-based treatment, UK-based figures, but you all know the figures in your own countries. But we can see that in the UK, we have more than 56,000 new cases of breast cancer every year. And 11,200 people will die from their breast cancer. However, what is a good story is that we have two-thirds of women who will survive their breast cancer for 10 or more years. That means in the UK, we have 600,000 people who are alive after the diagnosis of breast cancer. And this is going to rapidly increase with all the changes that we have, both in the incidence of breast cancer and also the success that we have in early breast cancer treatment. And we're likely to have 1.2 million women alive by 2030. Out of those, it's estimated that at least a third of our patients receive chemotherapy. On top of the chemotherapy, we go on to the next slide, we'll see that in breast cancer, we of course have very multimodal treatment. We go from surgery to chemotherapy to radiotherapy, targeted treatments, hormonal therapies, and as we can see on the next slide, that these treatments can go on for long durations of time. So we're giving chemotherapy, neoadjuvant or adjuvant, for up to 4 to 6 months, surgery, radiotherapy, which goes on for a week to 5 weeks, HER2 targeted treatment for 1 year, even 2 years, endocrine treatments for 5 to 10 years. And now we have our adjuvant CDK4/6 inhibitors that we're giving between 2 and 3 years, adjuvant bisphosphonates. We may have adjuvant PARP inhibitors and immunotherapy for a year as well. And these treatments are only increasing as we have more and more agents that are being approved. And of course, many of them will have short-term side effects, and we do tend to be more focused on the short-term side effects, but there are also long-term side effects which we may not be so well looked after by the clinics that we are doing, as we don't really keep hold of our patients. Certainly in the UK, patients get discharged and we don't have a good idea of how patients are managing years after they've completed some of the more intensive parts of the treatment. So if we go to the next slide, we can see that we always stage the cancer, but are we also staging the patient? And what I have begun to think about is that we should always stage the patient as well. What do the patient's symptoms? What are their worries or concerns? Do they have additional care needs? And when we treat the patient, when we're giving them their treatments, be they chemotherapy or their targeted treatments, then are we managing the symptoms that they have of the cancer, but also of the side effects of their treatment? Are we giving them the psychological support that they require? And then, of course, we always treat the tumor, but are we neglecting the person whilst we're treating the tumor? So it's important to assess the person, treat the tumor, and be aware of the comorbidities that the patient has. What is their performance status? What are their prior treatments? What are their drug treatments? And certainly in my practice now, I am beginning to think more and more about prehabilitation as well. Are we allowing these patients time to get a bit fitter, looking at their nutrition and recommending that they get stronger and fitter before they start the treatment? Because inevitably there will be a few weeks, and even in 2 to 3 weeks before patients start treatment, they can increase some of their cardiovascular reserves, they can increase some of their muscle mass. So this is something that we don't necessarily focus on as oncologists, as surgeons, as part of the multidisciplinary team, but it's clearly something that would be very beneficial for patients. Now, if we come to the actual treatment, we know that maintaining dose density is important, particularly with chemotherapy in terms of outcomes. If we maintain more than 85% of the dose intensity, it is associated with an improved disease-free survival and overall survival, which means that we do need to try and manage the side effects so that we can maintain that dose intensity. So if we come to the next slide, we can see that there are some key toxicities across the various different modalities, which really can lead to a reduction in the dose intensity. With chemotherapy, if we don't manage neutropenia or neuropathy, mucositis or cardiotoxicity, it leads to dose reductions, dose delays, and potentially even stopping the treatment. The endocrine therapy, Emma has spoken about very well, and we know that about 40% of patients don't actually adhere to their endocrine treatment due to the side effects that they have, and therefore they're clearly not going to be benefiting from a treatment that they are not adhering to. Our HER2 targeted treatment, which we will be giving to approximately 20% of our patients, are associated with cardiotoxicity. And now with the newer HER2 targeted treatments, with the ADCs, be it trastuzumab deruxtecan or some of the other ADCs, we know that there is a degree of pneumonitis. So far, this has been in the metastatic setting, but we know that there are trials looking at this in the earlier setting, the neoadjuvant setting, and in the adjuvant setting. And a number of these trials will be presented in the forthcoming ESMO international trial, and we'll see that there are some positive outcomes from these trials. So these drugs will be coming into the earlier setting. And so these are newer toxicities that we are managing for our patients, as well as the traditional side effects such as diarrhea that we are somewhat better. The CDK4/6 inhibitors have become a mainstay in our adjuvant treatments as well as our metastatic inhibitors and metastatic treatments. So we are now giving 2 years of abemaciclib adjuvantly, 3 years of ribociclib adjuvantly to our intermediate and high-risk patients. And these also come with side effects such as neutropenia, diarrhea, fatigue, QTc prolongation. If these patients don't have the required dosage adjustments, then they are not going to tolerate the treatments, they're going to stop the treatments, and their quality of life is going to be inhibited. And then we have immunotherapy primarily in our triple-negative breast cancer patients, which can cause a whole host of side effects, a bit like an inflammation of almost any organ. And this can lead to treatment holds, significant treatment with steroids, endocrine replacements, and other more significant treatments that will have to be administered while patients are an inpatient. So coming to neutropenia and febrile neutropenia, this is the leading cause of dose reductions and delays in chemotherapy. And in any chemotherapy regimen where there is a risk of neutropenia or febrile neutropenia between 10 and 20%, GCSF prophylaxis is given. In those regimens where there isn't primary prophylaxis, then there should be secondary G-CSF given after one episode of neutropenic sepsis. And the goal is, of course, to maintain this relative dose intensity without compromising safety, as there is clearly a mortality associated with neutropenic sepsis, which must be avoided at all costs. Coming to peripheral neuropathy. Peripheral neuropathy is a real dose-limiting toxicity with the taxanes and the platinums, and it can be deeply unpleasant for patients and can be a little bit idiosyncratic. There is, of course, a dose-related level of neuropathy that occurs, but in some patients it does seem to occur very early as well. And the management is, of course, dose adjustment, so reducing dose, holding the dose of treatments, and sometimes it really isn't possible to stop. It really isn't possible to continue, and therefore either the treatment has to be just stopped or consider an alternative agent. We do have treatments such as duloxetine, gabapentin, pregabalin for painful neuropathy, but really in this situation, it should be prevention rather than trying to give painkillers to mask the neuropathy. Recently, there's been a clinical trial called the POLAR trial, and this actually looked at hand cooling and compression. It was a randomized controlled trial looking at patients with these gloves and these kind of socks, which were extremely cold, a bit like the cold cap, which is used to reduce hair loss. And it did show a significant reduction in peripheral neuropathy in these patients, and it can be used by patients to reduce the amount of neuropathy or prevent it altogether, and is a good option. I think most health institutes don't really have a very good system for this, and I'm sure it will be something that becomes much more protocolized and something that we do have available to us. If we come to cardiotoxicity, we have a number of agents now that can be cardiotoxic, and we do have a whole new subspecialty of cardiac oncology, and we certainly work with cardiologists who specialize in cardiac oncology so that we can really have good management of our patients, early interventions and support. So anthracyclines have been a mainstay of our treatment for decades now, and a mainstay of our treatment for decades. And I'll continue. I think there was a bit of backplay there, along with HER2 agents. And these can, of course, lead to a decline in the ejection fraction, and therefore do require monitoring every 3 to 6 months, as well as baseline, followed by echocardiograms once the treatment has finished. These patients, again, coming back to the idea of staging the patient and ensuring the patient is well, and making sure that any cardiological input is optimized for the patient, so that if they do have any cardiac comorbidities, then those conditions are optimized. Hypertension, ischemic heart disease, and their medications are optimized prior to starting any treatment. We also will do regular troponins and a natriuretic peptide to ensure that there isn't significant cardiac damage whilst the patients are on these treatments as well. Again, if the patient is having significant problems, if their ejection fraction drops, then it may be that these patients do need to pause the treatment or even stop the treatment to prevent them from going into heart failure. Then we come to GI toxicities and mucositis. We know that diarrhea is very common with a number of our treatments, be they the CDK4/6 inhibitors, HER2 tyrosine kinase inhibitors, and a number of our chemotherapy agents. Loperamide is a very good drug to stop the diarrhea from occurring, and also, of course, what's important is to ensure that patients have reasonable expectation of what to expect, and know when to start these treatments so that they can tolerate the chemotherapy or the other agents, and they can keep the dose intensity appropriate to improve their outcomes. We know that mucositis can also be a significant issue, and advice for good oral care, seeing their dentist early and managing this will help patients to not only prevent mucositis, but also to keep their nutritional status optimal as well. Nausea is a fear that many patients have for their treatments, and we know that chemotherapy can be very emetogenic. We have very good anti-emetics now, and it's important to try and get the right type of prophylaxis for patients, and also for them to go home with the appropriate anti-emetics to prevent nausea and vomiting, and to improve their quality of life whilst patients are on treatment. If we move on to immune-mediated adverse events, immunotherapy has become standard of care in triple-negative breast cancer. And overall, we know that immunotherapy is fairly well tolerated. However, we also know that there are those patients who will have very significant toxic side effects from immunotherapy, and we really have to keep a very close eye on these patients, as to a degree these side effects can be a bit idiosyncratic. So it can affect any organ, and therefore it is important to know the patients and to assess the patients correctly. And the mainstay of managing these side effects is usually to either replace any hormonal deficiencies, such as using thyroxine or steroids with prednisolone or hydrocortisone for adrenal insufficiencies. But in other situations, such as problems with rashes or pneumonitis or colitis, the patients will need to be started on high-dose steroids to try and reverse these immune-mediated adverse events. I think all of us who have treated patients with immunotherapy know that some of these side effects can take a long time to settle down, and these patients can end up on steroids for a long period of time, as well as some of the other agents to try and do steroid sparing. Next slide. So we've touched on some of these with the thyroiditis, adrenal insufficiency, but of course we can get pneumonitis, colitis, hepatitis as well. And the management is, of course, the steroids and hormone replacement. And it is important that we are very much aware of all of the side effects that can occur, so that we recognize these side effects very early, and we can therefore stop the immunotherapy if necessary, and we can prevent further damage by treating patients appropriately with steroids and other steroid-sparing agents. So what are the practical managements? What do we do? So the general strategies that we have to use are, of course, to hold the treatment, to reduce the doses, and potentially switch the treatment if we have an alternative. In drugs such as the CDK4/6 inhibitors, we feel much more comfortable in reducing doses, as we know from the clinical trials with the CDK4/6 inhibitors that reducing the dose does not impact on disease-free survival, and therefore we would be much more comfortable in reducing the doses of these drugs. With the HER2 targeted treatments, it is important to hold the treatment and to get early cardiology input, and to start these patients on cardioprotective agents such as ACE inhibitors, beta blockers, to try and help with the cardiac remodeling. The endocrine treatments I won't cover, as of course Emma has just given you a very good talk on this. So what are the most important things to add in as supportive measures? We have a huge number of drugs that are available to us now to support patients, and these are getting better every few years. growth factors to try and reduce neutropenia with GCSF, and also growth factors to help with anemia, which are not available easily in the UK, but may be available wherever you are, such as EPO to treat anemia. We have many classes of antiemetics, the 5-HT3 inhibitors, NK1 inhibitors, and olanzapine has recently been added by ASCO to help with nausea and vomiting. Neuropathy and pain management, usually the best way of managing this is prevention rather than trying to use painkillers. And then we should always ensure that cardiac and bone protective strategies are implemented to prevent cardiac damage and to adhere to bone protection. And the most important thing is always to ensure that the patient is aware of what is to come, what may come, and that they have the set of tools which they can use to try and help manage their side effects. This will help their adherence and ultimately will improve outcomes for them, both physical and psychological. Next slide.
Is that the correct slide, Fharat?
Next slide, please. So we know that to keep the patient physically and psychologically able to take the treatments, we do have to motivate them to take the treatment, but always balance efficacy versus the toxicity. So to maintain the dose intensity while protecting their safety, intervening early and anticipating side effects and treating them as soon as they occur. And also ensuring that we have a multidisciplinary and collaborative approach to patients so that they are able to use their breast care CNSs and acute oncology to help support them. Next slide. So the take-home messages are that we should try and maintain dose intensity for our to improve our outcomes for chemotherapy. We need to try and prevent serious effects, both short-term and long-term, by implementing dose reductions and proactive supportive care to help with adherence and to use a multidisciplinary approach. Thank you.
Great talk. Many thanks for that, Fharat. Let me just try to stop sharing. And if we open our cameras, we'll discuss things for about 10-15 minutes. We managed to add Terri Coutee. Terri is one of the patient advocates, so I'm not sure if I've just added Terri without taking even her consent. She's runs the DFC Foundation, so it's great to have her online. Hi, Terri. How are you? You're on mute, Terri.
Yazan, you know, I'm East Coast or West Coast. You always catch me off guard, and here I am in my early morning gear, but with my coffee. So I'm ready. You're worth getting up for.
So there's quite a few questions on the Q&A section. So we'll go through a couple of them before we go to the next section. And Emma, somebody's asking, what's CBT?
I think I've answered most of these, Yazan. I've been through and I've answered as many as I can.
Perfect.
But
So
the ones I've left,
yeah,
which you might want me, is there's been a couple about sort of triple negative breast cancer and HRT. So I thought I'd leave that one to verbally respond to maybe as best I can.
let's start with that then.
Correct me if I'm wrong, Farah, in terms, I think this is very opinion based, but I think the answer is that, I mean, HRT is a whole other discussion really, but it is true to say that in the HRT studies that were done, there was a suggestion of increased risk of recurrence in ER positive breast cancer, and in the ER negative population, the studies didn't necessarily pick that up, but those studies have all sorts of flaws attached to them for various different reasons. And I think my approach tends to be that, again, like all these things, it is a discussion with the patient. I think that when someone's had a breast cancer, we all know there is risk of, it is a risk factor for another breast cancer, and that other breast cancer could be an ER positive breast cancer in the future. So I don't think HRT is completely risk-free. But again, it's about discussion and education. I don't know, Farah, whether you have a different view on it.
Yeah, I totally agree. I mean, it has to be a discussion with the patient, and it has to be, they have to make a decision based on what their quality of life is,
Yeah.
what their symptoms are, how they feel they are managing at that time, and to understand what HRT may or may not do to help some of
Yeah.
those side effects or symptoms, because it is not this kind of, magic potion either. It doesn't reverse everything. So I think
No.
it would be needing to understand what their symptoms were. In terms of, increased risk of breast cancer, yes, even triple negative breast cancer patients may have a slightly increased risk of other cancers. But again, I would say that that needs to be balanced against what their side effects of the menopause were. And
Yeah.
if their lives were, totally ruined by the menopause symptoms, then it may be that they would want to go onto HRT and they would need to be supported in that. But it's very hard to say that we would support somebody in making that decision versus recommending. And I think that's where the difference lies.
Yeah, it's education,
as
isn't
breast
it?
oncologist, we can't say that we recommend HRT, but we can certainly support those women who feel that it really is essential for their quality of life.
Yeah.
It's all about quality of life. We had two full webinars on HRT, and there's always lots of discussion on it.
Always, yeah.
We always say if it's non-hormonal, better than hormonal. If you need hormonal because of symptoms, try topical before systemic. And if you need systemic, you need to have that discussion. It's all about quality of life.
Yeah.
With the
Absolutely.
with the Vagifem, we always talk about if you want a short term, I always say short term, that's not a major issue. If it's a
Yeah.
long term, then we'll become a bit uncomfortable if they're on AI, as you said, they might need to switch to tamoxifen, but that's where I send them to the clever people. I send them to you, Emma and Fharat. So get out
Thanks, Yazan.
Yeah, we always love that.
Terri, any comments on from that point of view, from the patient point of view?
Well, I have to say, Fharat, I really, really appreciated your comment about treating the person versus the patient, because so many of these side effects, so many of these drugs, which we know have great efficacy, hold, really debilitating side effects for many, not everybody, but for many. One question I do have, or maybe a comment, I was at a conference last week in Portland, a lot on this very topic. One of the things I didn't hear mentioned this morning, and I would like any one of the panelists to comment on it, with vaginal atrophy. So, the estradiols are very kind of controversial in their use. However, I didn't hear anybody mention pelvic floor exercises.
So
Yeah.
exercise is in the second half. I'm hoping that it will come into the equation second half, because it's all about lifestyle measures. That's why we have Jay and Marjolin and also San. It's about lifestyle measures, about weight, about other things. But yeah, exercise is an important part of that.
Yeah, I think, was that not on your list, Emma?
Probably not, but I think again, this is a specialist physio, and certainly I think that women do need referral to specialist physio for pelvic floor, vaginal dilators. There's lots of different things that a specialist gynae physio can do to support a woman through the, genitourinary side effects of menopause and endocrine therapies.
Yes, because I feel like there's a lot of women these days who would like alternatives to prescription medication, and to at least try those alternatives. And then the other quick question I had, are there any studies being done post-menopausal, post-AI treatment for women who are using estradiol? Because I know we talk about, there's a higher incident, or a more increased incidence, I guess, for women on AI. Have you done are there studies on women post AI treatment who are using vaginal estrogen creams?
I mean, that's an excellent question. I haven't seen those.
I don't think there are, no.
And I was going to say, I doubt, those sorts of studies, although they sound like they should have been done, in terms of the funding for such studies and in trying to recruit those sorts of studies, it's very difficult to do them. And really, that kind of information would come from a real world evidence database. And we're not very good at being able to do that. But maybe we should start.
But I think there was a question in the chat about that, actually. And I think, again, this is a nuanced discussion, patient to patient, isn't it? And if someone's been on endocrine treatment for 5 or 10 years, hopefully they're at their lowest risk point at that moment. And if they need vaginal estrogens for quality of life and function is the key, then, we certainly don't have data to say it's not safe. We don't have data either way, actually, but I think women need to be supported to make the right decision for their own body.
So a couple of other comments before we go to the next section. You mentioned the study, Fharat, about the cold compression of the hands and maybe the gloves for preventing or decreasing the chance of having peripheral neuropathy in patients. And we have people from all across the world. So you have people from Sub-Saharan Africa, you have people from the subcontinent, from South America, more than 100 countries. Now, will simple compression gloves and simple compression stockings decrease those neuropathies?
This was a study done, I think, funded by Paxman, and I think a lot of the cold cap companies, a lot of the cold caps in your chemotherapy suites will be by a machine by Paxman. So that's basically just a refrigerated headpiece that sits on the head whilst you prior to the chemotherapy, during the chemotherapy, and after the chemotherapy. So the trial was done using a similar concept where there were gloves attached to this machine, which not only compressed but also were very cold. And they were worn before the chemotherapy, during the chemotherapy, and for a short period after the chemotherapy. Now, of course, those machines have not been rolled out. We don't have them. But what a lot of patients have done, having read about this themselves, actually, and that kind of peer-to-peer information, which is always a really good way for people to get information, that they are buying gloves, compression gloves, and coming to the chemo suite with a big ice box with the gloves that have been put in the ice box and then wearing them during their taxanes. And a lot of women have taken it upon themselves in my practice to do that, to prevent neuropathy. So I think that is something that wherever you are in the world could certainly be adopted.
And the other thing, there's lots of comments also on the Q&A section about HRT. We're not going to go to HRT, and we're all aware of the big JAMA study that looked at vaginal estrogen. The data is very interesting from the different studies, and we can look at that at a different day. I want to mention another thing that us as surgeons are not always aware of. Sometimes, as mentioned by Lorna Makhati online, many thanks for mentioning that, Lorna. Sometimes the brand, the make, so you have letrozole made by a company, you have no side effects from it. They change it to letrozole made by a different company, and you struggle with the side effects. So it's very important for the patients to know what is the make of the tablets that they used, and if certain make does not work for them, let them try a different make before you switch them to a different tablet. Any thoughts on that, Emma and Fharat?
Yeah, I spent a long time, and I suppose I feel bad about it. I spent a long time trying to convince women that it wasn't true, that whether you bought your treatment from X brand or Y brand, it should be the same. And I'd give the example that if you went and got paracetamol or Tylenol from one place or another, it would still have the same effect. But so many women say it that I feel it's got to be something in it. And I don't understand myself why the excipients, which shouldn't matter. So what we're saying is that the excipients are causing the side effects rather than the actual molecular drug. And why excipients should be causing such significant side effects, I don't understand it. I don't know what the rationale would be. But I think we have to believe women who say that they get on much better with one brand than another. And my view is, if you really believe that one brand is better for you, then please use it. The problem comes that sourcing that same brand repeatedly is very difficult. And usually as doctors, we have nothing to do with procurement, excuse me, procurement of drugs. So ensuring that a woman gets the same brand becomes quite problematic. And that's where the issue lies.
And Marjolin, Jay, and Sane, any comments about the first half of the webinar? Any things that you want to say?
They've been outstanding presentations and really great. And I think we'll talk after my talk about the real importance of exercise and helping to mitigate many of the side effects that we've talked about. I noticed that Fharat's got exercise equipment behind her there, so obviously she's a real believer in all this.
Perfect.
Yeah, there you go.
Perfect. And any comments from Marjolin and Sane?
Yeah, I think it was a really, really nice presentation too. And I think that the weight gain and in hormonal therapy is a big thing, especially also in the light of recurrent breast cancer. So sometimes a medal has two sides, or a lot of medals have two sides, isn't it?
So we will hear more about that in a couple of minutes now from you, Marjolin. One other thing I want to mention, there's lots of surgeons online. We're starting to see immunotherapy lots. Please, before you take them to theater, have a look at their electrolytes. If they're a bit funny, make sure they don't have any endocrinopathy. It's not a bad idea to have a thyroid function test after they had their chemotherapy or their immunotherapy, because you never know. Some places are already recommending to check that they don't have any adrenal insufficiency and any thyroid abnormalities. So please have a look at their bloods before you take them to theater. The next half will be mainly about lifestyle measures, breast cancer, and exercise. And the first talk will be joint talk between Marjolin Smidt and Sani Engenen, and they're going to talk about lifestyle measures and breast cancer. So Marjolin, do you want to try to share your screen and see how things go? You're on mute, so I cannot hear you, Marjolin.
So that is perfect, because I will start our presentation, but I'll wait patiently for Marjolin to open it.
Because I think she sent it to me just in case if it's not working. But it worked earlier today, so let's
Yeah, it worked. Yeah.
Listen, I will share my screen. Can you see now, Marjolin?
Am I screening now? Am I sharing now?
I'm not sure if it's me or you sharing the screen. One of us
We'll
is
find
sharing.
out.
We'll find out soon. So
Yeah.
you want to move your slides and see if you are sharing the screen. Yes, it is you. See, that's fine. It's you. So the next 15 minutes, 20 minutes are you and Sani's. Thank you.
Yeah. So maybe, Yazan, you're also sharing something, because I don't see the slides now. But of course, in the upcoming 15 minutes, now I do see the slides. That's perfect. So in the upcoming minutes, we are going to talk about lifestyle and breast cancer and how we can prevent the occurrence of breast cancer or recurrent breast cancer, because after the very excellent talks of Emma and Fharat, we also heard a lot about the side effects of treatment and how great would it be if we could all prevent that. So we're going to talk about the relationship between lifestyle and cancer. We're going to talk about the role of lifestyle after breast cancer diagnosis and how to act as physicians. So there are no relevant disclosures, and I would like to have the next slide. And I mentioned it before, the impact of cancer is really like a tsunami. And that is true from every point of view. So it is for the patient, for her family, for friends, but also has a huge societal impact and an impact on our economy. And it would be so much better to prevent cancer And what we see in the Netherlands is that there is a growing number of cancer patients throughout the years. This is true because of age, but maybe an even more important factor is lifestyle. The increase in cancer incidence probably also is related to lifestyle. And then we think about exercise, we think about smoking, obesity, diet, we think about alcohol, how we sleep, how many stress we have. And there is increasing evidence for every single factor. I mean, we all know for a very long time already the relationship in lung cancer. And in Holland, we have about 14,000 new patients a year diagnosed with lung cancer, and 90% of them, so over 12,000 patients, is smoking related. And this is also true for breast cancer. There are many lifestyle factors of which we know already that they increase the risk of breast cancer, and amongst those are alcohol, smoking, and overweight or obesity. And I would like to go into the last factor firstly. So what do we know about how overweight or obesity increases breast cancer? There are many factors influencing the increased risk of cancer in obesity, but probably there are three very important factors. The first, and like the fat cell is the important clue in this. So one of the most important factors is, of course, the fat cell producing estrogens, making sure that cancer cells might divide quicker, especially after menopause, where your fat cells are the most important estrogen producer. Furthermore, we see that people with obesity have an increased insulin resistance. Therefore, their levels of insulin will increase, and also other growth factors. Insulin also is a growth factor which may cause cancer cells to divide more rapidly. And then also in these fat cells, it is kind of a sterile inflammation. So there's all kinds of macrophages and all kinds of cytokines encouraging cells to divide more rapidly. So those three factors probably are the most important in the increased risk of cancer in the overweight patient. What we see is that the share of ER-positive breast cancer is increasing. And this is important because if I can have the next slide, we see in the right graph, we see the increase of overweight in Holland during the years, and you see that the ER-positive breast cancer is rising at the same pace as the overweight is rising. And it is important to realize that the ER-positive breast cancer risk is especially increased in postmenopausal women. We can see on the next slide. And it is a bit tricky, because what we see is that for ER-positive breast cancer, obesity is a risk factor in postmenopausal women. However, in premenopausal women, obesity increases the risk of triple-negative breast cancer. So it is the other way around, actually. Can I have the next slide, please? So if we see the incidence of ER-positive breast cancer, And we see that obesity is responsible for at least 1/3 of all ER-positive breast cancer. That means that it is responsible for about 1/4 of all breast cancers. And in the Netherlands, that will be almost 4,000 patients per year, with an incidence of around 16,000 new breast cancer patients per year in the Netherlands. And then it doesn't stop after the diagnosis of breast cancer, because we also see that with overweight or obesity, the impact of chemotherapy or hormone therapy is less. We see more complications from our cancer treatment, and we sometimes see even treatment restrictions because of obesity. We see that people tend to have more distant metastases, and they have a poorer cancer survival and overall survival. And of course, they have a worse quality of life. And then after our radiotherapy and after our surgery, we see a lot of complications because of obesity. We see more seroma. We see with our breast reconstructions more loss of the flaps. We see more prosthetic loss, more inflammation, more lymphedema, and much more, all related to obesity. And we see less impact of anti-hormonal therapy. And I think I'm going to give the word to Marjolin to talk about that.
Okay, so what was expected with aromatase inhibitors, where conversion of to estradiol and peripheral fat is blocked. So a lot of people thought that standard dosing would not be sufficient. So that was examined in several studies, and in 5 out of 7 studies, the benefit was smaller in overweight and obese patients. And actually, nobody really knew whether it was due to lesser effect of the AI, or due to the overweight or the obesity, or maybe due to increased taking of the medication as a consequence of increased joint and cardiovascular complaints. And what about chemotherapy? Actually, BMI had no impact in various studies on chemotherapy tolerance. And the full weight-based chemotherapy could be given in overweight and obese patients. But something else happens, because what is seen in various studies is that the PCR rate is lower in case of neoadjuvant systemic treatment. And as we know, PCR rate is a kind of surrogate for disease-free and overall survival. And what we further see is more recurrent disease, a lower disease-free and overall survival. And if you have a look, if you Google around, you find a lot of studies on this topic. And why? This is all about these estrogens, this inflammation, and this insulin resistance, which play an important role, which Sanne has already showed. And there's actually, there is a study which shows that neutrophils take circulating tumor cells to distant metastatic sites in obese mice, actually mice. But they kind of act like an Uber, since the immune system is not as awake as it should be. And here are more studies on the impact of increased insulin resistance, about the cytokines secreted from adipose tissue, about the role of immune system. There's a lot of evidence. And this hurts me kind of the most, because they have a significant lower quality of life. And that is because of the higher BMI itself, but also because of the combination of higher BMI and cancer. And then we didn't even talk about other lifestyle-related issues, such as sleep deprivation, medication such as medication they take for people take for COPD or asthma. Because why do I especially mention this medication? Because it makes losing weight almost impossible. We're taking Pantosol, corticosteroids, and these medications are so common. Depth and stress also play a significant role, and we didn't even talk about alcohol. So what to do is discuss it. So in addition to surgery, radiation therapy, systemic therapy, we also have to talk about lifestyle. We have to talk about exercise, medication, BMI, smoking, alcohol. We have to put this card on the table. And when the diagnostic consultation of breast cancer might seem the worst moment, but it is the best moment because people are really teachable at that moment. And there's a lot of evidence, but why I think that the gynecological study on cervical dysplasia and its close relation with smoking is one of the best studies. Because I think a lot of people say on New Year's Eve, oh, I'll quit smoking. Don't smoke, but a lot of people do. And the chances for successful quitting are 4% at New Year's Eve. If you warn a patient for the risk of smoking at cervical dysplasia, the chances for successful quitting are 40%. I don't think we need to burden the patient with all lifestyle things, but choose at least one of these lifestyle anchors and make a referral plan for quitting smoking or whatever, or join a lifestyle clinic. Make a plan yourself. Why? Because it is highly likely that a decrease to normal BMI might result in more gain than chemotherapy in ER-positive postmenopausal breast cancer patients. And I know that this is a very harsh way of saying it, but I'm Dutch, so I'm blunt, but I think this is getting close to the hazard ratios of both. And what we see in, just to show you something about the impact of bariatric surgery on breast cancer incidence, that already has an odds ratio of like 0.2 after only 5 years on a breast cancer risk. Isn't that an amazing risk reduction? And I think you wouldn't have suspected it. And the same accounts for a healthy lifestyle change. That also has a really, really good impact after breast cancer. And there is this DELCUP study. That is a study in high-risk breast cancer patients, stage 1-4. And after only, I thought it was like 3 years, there's already like almost 60% lower chance of mortality and a 37% lower risk of breast cancer recurrence. And that accounts for triple negative and HER2 positive breast cancer, because we always point at HER2 ER positive breast cancer in case of BMI, but it's not. It's everywhere. So why all this? Because we have to start mopping when the tap is still open. We have to close the tap. And cancer is only a small fraction of the over 200 diseases caused by lifestyle. So the gain here is so much bigger than what we will see in our outpatient clinic. Yeah, there was something.
Perfect. I think you're still sharing your screen, isn't it? Oh,
I stopped it. I even managed to do that. Isn't that amazing, Yazan?
Thank you, Fanny. It's a great talk. And now we'll come to Jay Harness from the States. And Jay is one of the senior surgeons from the States in Arizona, currently working, if I'm not mistaken. And he's going to talk about exercise. And he runs a lovely group about exercise and breast cancer. And he keeps everybody informed. So it's great to hear from Jay about this. Jay, the next 15 minutes are all yours.
Well, thank you very much. I'm sitting here with a big smile on my face because these 3 prior talks are the perfect segue to what I would like to talk about, which is exercise oncology, which is a term that most folks in the medical world haven't even heard before, let alone know that much about. I also want to acknowledge two other people who have contributed slides to this presentation. The first is Catherine, known as Katie Schmitz, who's a professor of hematology oncology, University of Pittsburgh Medical Center, past president of the American College of Sports Medicine, and the founder of Moving Through Cancer. And also Dr. Karen Wonders, who is a professor of exercise physiology at Wright State University and the founder of Maple Tree Cancer Alliance. Why is my slide not? There we go. Let's do it this way. If you remember no other slide from my talk today, please remember this one. This is sort of the history of the evolution of exercise oncology. Starting back in 1990 were some of the original randomized controlled clinical trials. Up through this year, we've now got over 3,000 of them, resulting in 30,000 publications. I have said to people, if we had this much science about a new surgical procedure, it certainly would have been standard of care a long time ago. And then when I say, why are we in oncology not familiar with all of this data and all these publications? The answer is really very straightforward. It's because these clinical trials were predominantly done by PhD, outstanding researchers in exercise physiology, kinesiology, and even sports medicine, and primarily published in their literature. So until the last few years, there's been very little crossover into our oncology literature. When I bring up the term exercise oncology, people say, well, what is that? And I think one of the ways of thinking of it is an adjunctive therapeutic approach to cancer patients that have emerged from these over 3,000 prospective clinical trials conducted over the last 35 years. And as we've already been talking about, when we talk about the side effects of chemotherapy, hormonal therapy, and lifestyle issues, these clinical trials have resulted in moderate to strong evidence of the positive impact of exercise on the patient's fatigue, their anxiety, their depression, their quality of life, physical function, sleep, bone health, and breast cancer-related lymphedema, not only in the prevention of lymphedema, but also in the treatment of lymphedema. It's important to remember that exercise oncology programs are evidence-based programs of, and here's the key words here, supervised, individualized exercise training done on site or virtually. And our goal is to try and make exercise oncology programs an international standard of adjunctive care, as it already is in Australia, who are some of the real important world leaders. And I think it's also important for us to think about exercise as medicine, which has come from the American College of Sports Medicine. Now, Maple Tree Cancer Alliance in Ohio, that I'm affiliated with, has a prospective database. And here's some data from 11,248 patients on the physical and psychological impact of exercise programs during active treatment. Nearly a 60% increase in quality of life, increased cardiovascular endurance, muscular endurance, flexibility, and here's really important, nearly a 76% increase in feeling more positive and nearly a 60% increase in feelings of support. People then bring up all the time, is there a financial impact of these kinds of organized programs? And again, from the Maple Tree database, they have found a decrease in hospital inpatient stay by about 6%, decrease in length of hospital stays by nearly 20%, a big decrease in emergency room visits by nearly 30%, decrease in overall total patient encounters by a third, 33%, and a decrease in readmissions approaching 50%. If you look at all this data, and I should have pointed out on my first big slide, 65% of the clinical trials that have been conducted over the last 35 years have actually involved breast cancer patients. And if we amalgamate all the data from these studies, what we see is about a 31% reduced risk of cancer-specific mortality, a 22% reduced recurrence rate. And here's the biggest impact of all, whether it's in breast cancer or other cancers, a reduction in all-cause mortality of around 41%, and particularly in cardiovascular disease. If we talk about what's the prescription for exercise during active treatment and into long-term survivorship, the national and international standard is 150 minutes a week. And I really want to emphasize this. We're talking about moderate intensity exercise. As a good example, 5 days a week of walking briskly for about 30 minutes and 2, maybe 3 times a week of resistance training. Many people have thought, Jay Harness, you're advocating for the Ironman competition or training for marathons. No, I'm not. I'm advocating for some moderate intensity activity. Here in the US, the National Accreditation Program for Breast Center Standards were revised and released last year, and now the standards ask centers to document policies for exercise recommendations. The ASCO guidelines that came out a few years ago, this is important to read these. Oncology providers should recommend regular aerobic and resistance exercise during active treatment with curative intent to mitigate the side effects of cancer treatment. This means with curative intent stages 1 through 3, but even more data is coming about the benefits of patients with stage 4 disease. If you look at the NCCN survivorship guidelines, they're virtually identical to these. So we've got big name groups, including ASCO, NCCN, American Cancer Society, the National Cancer Institute, and others here in the US that are strongly advocating for these standards. In the NAPBC standards, what we're talking about are programming, referring for exercise programming, including part of the pre-surgical assessment, has been already pointed out in prehab, getting patients ready for neoadjuvant chemotherapy for triple negative or HER2 positive breast cancers. There's a lead time here of a few weeks. Let's get our patients moving. Post-surgical referrals, particularly during chemotherapy. A lot of the clinical trials that have come out about chemotherapy have clearly demonstrated better compliance with dose dense recommendations, better tolerance of chemotherapy, et cetera, and particularly in the long-term survivorship. Let me just highlight in the next couple of minutes some recent publications. Here's one from this year, Exercise and Survival Benefits in Cancer Patients, evidence from a comprehensive meta-analysis. This was 151 cohorts of 1.5 million cancer patients across breast, lung, prostate, colorectal, and skin cancer. Again, similar to the numbers I've shown you. In this study, the lower risk of death in cancer patients ranges from 31 to 36%. For prostate cancer patients, 27 to 37% reduction in mortality. Lung cancer, 22 to 24% reduction. Colorectal, and I'll talk about the challenge trial in a moment, a 29% lower all-cause and cancer-specific mortality. I have said to my colleagues repeatedly, if we had this much scientific data for a new surgical procedure of breast cancer, it would have been the standard of care 10 years or more ago. What about cost savings? One of the big barriers in the United States is not having reimbursement yet. Here's a lovely study done by Karen Wonders, Katie Schmitz, and others at Mapletree that involved 243 women with early stage 1 and 2 breast cancers, randomized prospectively to an exercise group of 123 people and a control group of 120 patients. It involved 12 weeks, again, of supervised, individualized exercise programs, aerobic, resistance, flexibility, following the American College of Sports Medicine guidelines. The exercise group showed significant improvements, and I've highlighted some of these already. Here's another study: cardiovascular fitness by nearly 10%, muscular endurance around 14%, strength 3%, flexibility, but with no improvements in any of these in the control group. The major cost savings were from fewer emergency room visits, unplanned hospitalizations, and decreased office visits. They actually try to quantify this in the control groups. It was nearly $8,600 per patient in costs, where the cost savings in the exercise group are around $6,300. If there's ever been a really huge clinical trial in the world of structured exercise after adjuvant therapy, this is the Challenge clinical trial that was just presented on June 1st at ASCO. In fact, I was watching it on live streaming with an audience, gave them a standing ovation after Carrie's group presented this study. This took, folks, 20 years to conduct, from inception to finally being presented at ASCO. It involved 55 sites, predominantly in Canada and Australia, as well as some other sites. 889 patients were prospectively randomized, about 442 to the exercise intervention, 447 to the health education group. The participants in the study had completed their surgery and their adjuvant chemotherapy for high-risk stage 2 or stage 3 colon cancers. The structured exercise group consisted of 3 years of behavioral support intervention designed to achieve 10 med hours per week of recreational aerobic exercise. This is the equivalent to brisk walking 3 to 4 times a week for about 45 to 60 minutes. The health education group received standard survivorship health education materials, but no structured exercise programming. The median follow-up here was nearly 8 years. The exercise group had a 28% reduction in recurrence of their original disease, a new cancer, or death. And the exercise group had an overall survival benefit by 37%. When this was presented and then simultaneously published in the New England Journal of Medicine the same day, it got a standing ovation at ASCO. And accompanying that presentation in the New England Journal was this editorial that talks about extending cancer survival with exercise, a time for oncology to act. And I couldn't agree more. And I would recommend this editorial and the study for everybody, excuse me. So here's the big question. We've got 35 years worth of improved clinical outcomes with exercise oncology program. I think the $64 question is, what's happening at the physiologically to give these results? And the focus right now is on 2 areas, the immune system and muscles. And this cartoon nicely demonstrates the anti-cancer elements released by the immune system with exercise: natural killer cells, cytotoxic T cells, macrophages, and something that most of us are not familiar with, which are myokines. Myokines are small protein particles that are both cytokines and peptides secreted by the contracting skeletal muscle during physical activity. They have a direct anti-tumoral effect, anti-inflammatory actions, immune system activation, and inhibitions of angiogenesis. Here's a paper that came out a year ago that really summarizes. I won't bore you with all of these factors that are released here, but as you can see, there are a boatload of things released. Now, when we talk about immunotherapy, as has already been pointed out, I think immunotherapy is a double-edged sword. We've seen really phenomenal results in lung cancer and malignant melanoma, where immunotherapy is standard of care for these certain types. But can these therapies become more active during neoadjuvant exercise programs such as prehab? And as has already been pointed out, are we really talking about a double-edged sword here? And I think we should talk about this during our upcoming discussions, because I'd like to think of the enhancement of the immune system as an adjunct to helping immunotherapies work better. And there have been reports in the literature in prehab or neoadjuvant exercise on neoadjuvant chemotherapy regimens, where in some of the reports there's actually been increased complete pathologic response rates. But anyway, this is a nice summary of what's going on with exercise. Exercise oncology programs there can be shown to have a proven effect on common symptoms of active treatment, can improve chemotherapy completion rates, are cost effective. Exercise oncology programs we need to really think of as a continuum of care from rehabilitation during active treatment and into long-term survivorship. And I'd like to hope that not only in Australia, but coming soon, this will become a standard of care everywhere. A recent publication that I would absolutely recommend that everybody take a look at from the Journal of the National Cancer Institute is a recently received monograph on the update on exercise oncology, and think of it as a multidisciplinary perspective around the globe, particularly Katie Schmidt's opening commentary here that has really come of age, and all of these other fabulous publications we've got in this journal. As I wrap up, let me tell everybody about the creation about a year or so ago of the International Society of Exercise Oncology, ISEO. This society is global. It's a society that is newly organized to increase awareness of the critical role that exercise plays in cancer prevention, as we just talked about with obesity, in the treatment, in the survivorship. The highest priority is changing this to make it a standard of care throughout the world. Our first inaugural meeting will actually be in Heidelberg, Germany next July, and the website is exercise-oncology.org. And then my final slide is about the website that I started about 10 months ago called Cancer Fitness. The website can be found at cancerfitness.org. This is all about the description of what the heck exercise oncology is. Plus, we have videos, written blogs, and other things. And finally, at the site, I've got an email list of almost 450 people in 24 countries. If any of you would like to be added to that email list, there's a link at the website to be added, or you can email me. This is my email address below, jkharness@gmail.com. Thank you for the privilege of your time.
Fantastic talk, Jay, and thank you for being part of this. Now, before we go to the question and answer session, there's a couple of comments. First of all, everybody that attended the webinar, if you haven't attended for long enough, I'll send you a certificate with 1.5 CPD points by the College of Surgeons of Edinburgh. I might be a bit late sending that to you because I'm in Mumbai next week, so I'll be traveling most of next week, maybe towards the end of the week, so don't expect anything till Saturday, Sunday time. But it will be sent, so please don't start sending me emails. Now, we have started planning the next few webinars. The next one is revision and symmetrization surgery. We have the likes of Steve McCulley from the UK, MJ Cardoso from Portugal. We have Ricardo Bonomi from Italy. We have Maher Hassan from Egypt, Anushka Chowdhury from the UK, and Farid Mayboudi from Australia, all confirmed they'll be part of that. And it's about seeing what we can do for symmetrization and revision surgery. The one after that is about B3, which will be an MDT type of discussion. We'll have a question before and after as we're starting to collect data to see if this online education is making any difference. because the first paper will come out of iBreastBook webinars. We're drafting that, and hopefully the next webinar, the B3, will give us some more data to see if we're making a difference. And then there will be another webinar in December time. What's new in breast surgery? And there's lots of speakers that are lined up for that. So please keep an eye. Please join the WhatsApp groups. Please join the email list. I think there's 18,000 of you on the email list. It will be great to hit the 20K number. Now, let's start discussing that. I still remember 2 years ago or last year, we had Liz Oridian on this webinar, and she talked about exercise, and she had fantastic talk about lifestyle measures, mainly from own experience. And there's lots of things to be said about diet, about weight, about smoking, about exercise. But let's start with Emma and Fharat. Of course, I'll put you on the spot. Is there any comments or any questions you have for the speakers?
Yes, thank you, Jay. I think that was a fantastic summary, and it is a subject which is really close to my heart because I think that we are not good at allowing patients to do things for themselves. We kind of very good at giving prescriptions of medications and treatments and telling them about all of our clinical trials that will allow them to be recurrence free, or if they are secondary breast cancer, how they could live longer. But we just seem to fail at empowering patients and really giving them the tools to improve their own outcomes. And I think exercise oncology has got to be one of the biggest things that we push in the next decade or so. I think every hospital, every oncology department, every cancer hospital should have an exercise oncology area. Whether that's exercise on site, whether that's somewhere where you can get information, whether that's somewhere where you can actually have resource. I don't know, but there has to be some protocols because it's clear. I don't think there's a person on this planet who doesn't know that exercise is good for you, but there's a whole load of people who don't do it. So why are they not doing it? So I think there needs to be the next step where we actually make people feel like they want to exercise rather than make them feel guilty about the fact that they're not exercising.
That makes sense.
Oh, those are outstanding comments. Thank you very much. What's really key here is for all of us, med-oncs, rad-oncs, surg-oncs, to make a referral, to make a strong recommendation to our patients to do it. Simply handing them a brochure doesn't work. We know the brochure therapy does not work. And so referring to programs out in the community, referring to medical center based programs are really key. We're dealing with the barrier in the United States of the lack of reimbursement. The group I'm with, Maple Trees, in over 80 locations in the US, often it's been the hospital foundations that will fund the programs or other philanthropic sources that will fund programs at the medical center levels. You've got groups like the YMCA that offer the Live Strong programs, but that initial push needs to come from us to our patients, okay?
Perfect. Let's go to Michalis. So Michalis is from the Italian channel, but Michalis is also Michael is one of the surgeons. So he has a question before we go to Emma. Michael, you need to switch to the English channel, otherwise we will not hear you. Perfect. No, we still cannot hear you, Michael. You just need to go on the English channel.
I hear him on the English channel. I do hear him.
Oh, it's only me that I cannot hear you. Then just you say
Yazan, you have faded away. I can hardly hear you.
Okay, it's my issue then. Let me see what I can do.
Yes.
Perfect. Yeah.
Yazan, I think there's a lot of people in the chat saying they can't hear, so maybe if we go to Emma.
I think I can hear. The problem, you need to be on the English channel. So look at the globe, choose the English channel, you will hear Mikhail. If you don't, if you're not on the English channel, you will not hear him. So what Mikhail is saying that no, no, not at all. So what Mikhail is saying is that he's a plastic surgeon. He always recommends exercise for people that coming for cosmetic surgery, but he never thought about it for cancer treatment. But for cancer treatment, it does make a difference. And there's papers to suggest that the recurrence is those exercises can be as powerful as endocrine treatment in some ladies. Emma, you wanted to mention something?
Yeah, I just wanted to sort of talk a little bit or comment really a little bit about the management of lifestyle factors in patients, exercise, weight control, alcohol, smoking, sometimes recreational drugs. But actually, a lot of this, and I don't know that we've mentioned it, pertains to the level of deprivation that you work in. And certainly myself and Farah work in communities that have quite a high deprivation index. And actually, it's very difficult, I think, to engage a lot of people who have a lot of social problems and actually can't necessarily access the right educational support or even just the basics to help them manage their lifestyle modifications. And actually, I think that's a major piece that needs addressing as well.
I agree with that, and I want Marjolin to speak a bit about the study she's designing. It's not only about during treatment, it's also about survivorship and later. So Marjolin, the protocol that you sent for Da Vinci is fantastic. Do you want to mention that?
Yeah, we designed a Vinci study, and it's a study which is, if we get the Horizon Money Grant, obviously, is including patients after standard breast cancer care and is randomizing patients to a combined lifestyle intervention for over 2 years. And it has to be a long period, like 2 years, to make sure that the whole change is sustainable. And the whole intervention is paid for by the grant organization or by the Dutch government. And I think that's a really important thing, because it doesn't make any sense if people don't have the money to buy running shoes to send them to running. And that's a really, really big problem. And that's why it's really nice that in Holland, we have a guideline now on breast cancer and lifestyle, and it's connecting the Dutch breast cancer guideline to the guideline on overweight and obesity, but it's also referring to exercise programs. And we have like a web all over the Netherlands, including all these hubs to sporting, to lifestyle coaching, anything. So that's we're really gracious for that, because that is really important.
Perfect. Terri, you want to say something?
Yes. Marjolin, I like your backdrop and your bike. Good job. What I would like to say, as a cancer patient who has been through chemotherapy, surgery, radiation, all the things, what exercise does, and what Dr. Harness talked about, is it helps breast cancer patients regain confidence in a body that they sometimes think betrayed them. So that's what exercise oncology does. And to your points, Marjolin, and saying about, what if patients can't afford a pair of shoes to go walking? Or what if they're in an environment where they don't feel safe to even get outside and walk because of their neighborhood? It does not cost anything to turn on some music, which is uplifting, and dance right in your space, no matter how big or how small it is. Movement is key. And if I can put in a shameless plug, because I am a total Dr. Harness girl fan, we have a video coming up. He talked about the cancerfitness.org website, and Dr. Harness goes through the entire website. Stay tuned. It will be published on the Deep Sea Foundation YouTube channel. That's my shameless plug for this morning. To all of you, thank you for this topic. It is so important in the breast cancer community and in the cancer community at large. So thank you very much.
Tanya, you wanted to say something? Because you had your hand up at one stage and it went down.
I dropped it because I wanted to point out some things about the Vinci study, but then you already mentioned that.
Perfect. And there's the elephant in the room that people are not mentioning, and I thought it will be mentioned by now. For example, a few years ago, if somebody had a high BMI, he's a BRCA carrier, I always try to send them and argue that if this patient loses some weight and they've tried exercise, they've tried dieting, it did not work, and if they're high BMI, why can't we send them for bariatric surgery to lose the weight and then offer them risk-reducing surgery along with reconstruction, because otherwise things will fall apart. But now we have the magic injections, the GPL-1, the Mounjaro, the Ozempic, all the Wegovy. What's the role of those? Any thoughts about that?
Well, I think the jury is out, really. I think that there will be a lot of data coming, probably real world evidence, to be honest, because there are so many people on this drug around the world. I think there's an estimate that 10% of the adult population in the UK is on this drug. So I think we'll have real world data. We haven't seen it actively tested in patients. There are some preclinical data from in vitro data looking at breast cancer growth, and it has suggested that there is a reduction in breast cancer growth, but that's not in people. So we can extrapolate a little bit, but I think we should be cautious in the way that we extrapolate. And I think we have to be guided really by the endocrinologists and the diabetologists with regards to this, in making sure that the right patients are accessing it. We never worry about our patients being on anti-diabetic medication, for example. So if patients are on metformin or semaglutide or some of the other medications, we wouldn't worry that they would interfere with breast cancer risk. And I think there have been some studies looking at metformin in reducing breast cancer risk, and the data were negative. So for me, I think that a jury is definitely out, and it would be a decision on a patient-by-patient basis in conjunction with an endocrinologist. I'm not going to be prescribing Mounjaro or Ozempic or any of the other drugs that I don't even know about.
Any other comments?
Yeah, one word of caution I think everybody's aware of with these drugs is not only are you losing fat, but you're losing muscle mass. Mm-hmm. And it's really important that this category of patients be exercising regularly. Can I ask Fharat a quick question? And that is the double-edged sword of exercise and the immune system and immunotherapy. Do you see exercise as an adjunct to improving the effectiveness of immunotherapy, or because of the side effects of immunotherapy, would it make those side effects worse?
Oh, that's a question that I have never been asked before, it's safe to say. I think a lot of the side effects that we get with immunotherapy are to a degree idiosyncratic, in my view. I don't think they're predictable, and I can never pick out the patient who's going to get a very severe immune-mediated side effect. I mean, the very severe immune-mediated side effects are meant to be less than 5%, and sometimes when they happen, they're absolutely terrible and very difficult to manage. But in terms of the other side effects, we know that rash and hypothyroidism are fairly common, but the others are all less than 10% in incidence. The microbiome has been cited a lot with regards to the effectiveness of immunotherapy, and how having a good gut microbiome is associated with having better outcomes in triple-negative breast cancer from immunotherapy. So without making too big a leap, I would assume that exercising would be in the same kind of camp, and exercise would be beneficial. Yeah, I would never tell you not to exercise.
Yeah, and there's also reports out on exercise improving the biome, the gut biome.
Well, we have 5 minutes left, and we have two hands. So we have Sania and Marjolin. Let's take some of the comments from them before we close. Sania?
So I just wanted to go back to the GLP-1 agonists again, if that's okay. I think we should be really careful to make them our holy grail, because I think as with bariatric surgery, you cannot use them alone. That's the first point. You really need the exercise to go along with it to have the lifestyle change. That's why in the Netherlands we are not allowed to prescribe them if a patient or a person doesn't has done like a lifestyle exercise course before using Ozempic or Wegovy or whatever. And the other thing is that is at this moment it is also a matter of equity, because at this moment reimbursement isn't arranged in a good way, at least in our country, but also in lots of other countries. So it is a drug that can be paid for by the people who can afford it. And I think that is not something we should allow to happen.
Marjolin?
Yeah, I want to say about the same thing, that at least the use of a GLP-1 agonist should be going simultaneously with the lifestyle change. That's a key issue, isn't it? And yes, in the MA32 study, metformin didn't use the cancer risk, which is the metformin anti-diabetic, but it did help satiety, and it acts kind of like a GLP-1 agonist light, and people lost a significant amount of weight, and significant is just like 3-4 kilos, which is quite something from an anti-diabetic, isn't it?
Yeah. So I think we're nearly coming to the close. It's nearly 6 o'clock here in the UK. I know it's only still 10 o'clock in the morning for you, Terry and Jay, maybe, but here it's nearly 6 o'clock in the evening. So any final comments from anybody?
Thank you for
Perfect.
the privilege of being here. It's really been
Yeah.
fantastic. Thank you very much.
Thank
Yeah,
you for
thank you.
giving up your time. And anybody that wants to watch this webinar, it is already live on the YouTube channel. A few people have started watching it there. So it's all for free. So if anybody wants to watch, I'll start sharing on the social media. Now, thank you for giving up your time to be with us today, and giving up 2 hours on a Saturday, which is a dear day for most people because of the family. Now, for people in the States, have a good morning and lovely day. For people in Europe, have a good evening. For people in the subcontinent and the Far East, have a good night. And thank you. See you in 4 weeks' time.
Bye-bye.